right, well, thanks for coming tonight. I'm a physical therapist and a certified athletic trainer by trade. I've been doing it for 22 years, which is hard to believe, but back pain is something that by volume is probably the number one thing that we will see as a physical therapist for treating due to pain and the disability that follows with it. So, by show of hands, how many people in the room have had some days where they've had some low back pain in their life? Every hand go up, please. Thank you. Okay. So there's obviously some interest in learning more about it from your guys' standpoint, but it really is prevalent in the society at almost 100% at some point. Most of the time, it's a transient phenomenon where it comes and goes, but some people, by the time they get to see us, in a lot of cases, it's a repeated, ongoing recurrence, and it's a pretty delicate process when you look at the anatomy and physiology of the back. There's just a lot going on that's different than any other place in the body because of the nervous system around there. So we'll start out and give just some definitions that I found. You could find a lot of different definitions online for low back pain and how they classify it and quantify it. The incidence of it, the cost of it in society in terms of healthcare dollars and things like that is pretty immense. So I provided some statistics. We'll kind of briefly go through those. And then we'll talk about some of the different conditions that are out there that you might get diagnosed with that bring into a medical facility, whether it's a physician, a physical therapist, a chiropractor, a massage therapist. A lot of people are out there to treat these types of conditions. So there's not always a right or wrong practitioner. It's what you feel comfortable with and what seems to help you. But low back pain defined, this is sort of the global burden of disease. There's a little foundation that sort of looks at different things that tend to afflict us, and the definition by them of low back pain is pain in an area on the posterior, the back-sided aspect of the body, from the lower margin of your 12th rib, which is right above the cut of your hip bone, to the lower gluteal folds, which is right at the bottom of your butt crease, kind of here above your hamstring muscles. Pain with or without referring into one or both of the legs that last for at least one day. Okay, it's a pretty vague description, but it's basically pain between the bottom of your rear end and your low back. So a lot of people think they have pain in their rear, and it's oftentimes called sciatica, or they think your sciatic nerve is irritated. Sciatica is sort of more of a catch-all term for pain that can emanate into the leg that's originating from the low back. So, if you came into the office and saw me and said, it's really not in my back, Greg, it's more in my rear end, top of my leg, we still would probably be referring to it as low back pain, or at least the origin of it is coming from that. So I like this definition because it does have a pretty broad distribution of what low back pain might be considered as. And in terms of incidence, the prevalence of low back pain in 2017 was estimated to be about 7.5% of the global population, which is lots of people. You can see 577 million. So these statistics are relatively recent, within the last few years. It's been the leading cause of years lived with disability since 1990 and remains a significant global public health concern. So, years lived with disability. So that's obviously, something that takes you away from enjoying the quality of your life, the things you do every day, getting in and out of bed, on and off of a seated surface, rolling over in bed, laying on your back or your stomach. Think about the other aid, the usefulness of what you do in everyday life. Can you clean your house? Can you bend down? Can you handle the vacuum cleaner? Can you carry laundry to the laundry room? Can you bend over into, all these things start looking at, the dynamic posture of the body. And again, years lived with disability can be sort of broadly defined, but when we look at having you guys come to an office and see us, we have you fill out what's called an outcome measure. And oftentimes those are some broad questions based on your tolerance and pain when having to go through standing, again, a broad category, sitting, your usual recreational activities, your work activities, lifting, your general pain number. And so there's about 10 questions, and that sort of defines for us, based on a score, it's repeatable over time, how much disability you have from your pain due to your back. So some of those things factor into living with disability. So most people that are defined with living with disability, it doesn't mean you can't function. It means you're functioning at a lesser extent than what you might normally if you didn't have pain. 85 to 95% of people presenting to primary care providers do not have a specific identifiable pathoanatomical origin for their pain, which, that's sort of a medical term, but essentially, there's no mechanism of injury, as we call it. So what did you do? Well, I bent over and lifted this up, and that's when something popped in my back. That might be more of a pathoanatomical thing. You hurt a disc, you hurt a muscle, you strained something. A lot of the pain we come in, people, it's called an insidious onset. I don't know what I did. I just woke up one day and my pain was there. Now it's been there for 2 weeks and it's getting worse. So there's no identifiable feature that says I did this and my pain started. Disability associated with low back pain increased in all age groups between 1990 and 2019 and was greatest in the 50 to 54 age group in 2019. And approximately 70% of years lost to disability were in working age people. So I suppose when we look at that years lost through disability, that's people that can't function in their home life, that's people that can't go to work, that's dollars in the healthcare system, that's time lost from valuable things that mean something to you in your quality of life. Again, some broad definitions, but you start to see that, you look at that top stat, affecting 577 million people across the world. That's probably a conservative estimate, to be honest with you, because that's only people reporting it. There's a lot of people that don't report pain, to healthcare providers. Other statistics, although less than 28% of people have severe disability, they account for 77% of the disability caused by low back pain. So less than a quarter of the people with severe disability have almost all of the disability. Does that make sense? So those that are severely disabled, while it's not great in number, they account for the greatest extent of what they are not able to do in their daily life compared to those, the other 70% that are mildly or not severely disabled. Over 80% of the costs attributable to low back pain are due to indirect costs such as loss of productivity, disability payments in countries that have functioning social welfare systems. So, this doesn't count for third world countries that don't have strong healthcare systems to take care of folks with low back pain. Those people just live and do, in spite of the fact that they have an injury. Factors consistently reported to be associated with disability and high societal costs of chronic back pain include aging, poor general health, increased psychosocial stresses, worse baseline functional disability, and then that probably goes back to those measures that we have people fill out in our offices. What's your baseline disability when you come in the door? So again, when I'm treating somebody, I don't make that as my only goal, but certainly that's something that we test over time. Every couple of weeks we have you fill out a new survey that says, okay, based on the initial scale we took, how are we making progress? Are we 1 point better on the pain scale? Are we 1 point better on the lifting scale? Sciatica and presence of compensation. Compensation meaning we're cheating somewhere in our body to kind of deal with the pain. Probably the bulk of what we want to talk about are the causes. When we say strain, we're really talking about a muscle. So a muscle attaches one bone to another and it creates movement. So when a muscle contracts, it pulls. When it gets stretched, it gives elastic tension, but it holds stability between two bony segments. From a dynamic standpoint, we think sprain, the second one down, that's a ligament. So a ligament attaches a bone to a bone. A ligament is more of a static placement holder for stability. So we can sprain those. We see them, let's take a knee for example. Someone as an athlete gets hit from a side angle, it forces too much stretch elasticity-wise on a ligament and it can tear. The same thing can happen in our back ligaments. We've got, 3 sections of our back, the lumbar, the thoracic, the cervical areas, 2 very strong ligaments covering the front of that, and then we have a joint at every single level. So there's 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then you have your sacrum, which is what often people call their tailbone down below. But each single segment has tensile elements that connect them together called ligaments. But what really protects them from a force standpoint is the muscles that surround them. So oftentimes, someone will come into our offices and they have back pain. They haven't had any diagnostic workup. No x-ray, no MRI, no scans. And it's not really necessary because we have little special tests that we can run that sort of tease out, what tissues are under stress or duress. But almost all cases, muscular strains are involved because the muscles, whether you hurt the muscle itself or whether the muscle's reacting as like a compensation for your pain, it will go into a spasm and tighten things up to protect you. Other causes of pain, discogenic. Anybody in here have a herniated disc or a bulging disc? Have they been diagnosed with that? What kind of pain do you get from that?
Radiating down my leg.
Down your leg, yes.
Burning, tearing sensation, tight IT.
This sounds like a lot of fun.
Yeah.
How about you?
Same thing.
Same thing?
Down the leg. It's fine now. I had therapy.
Comes and goes, right?
Pretty much it's gone.
That's good. Anybody else have nerve pain?
I had a ruptured disc, then I had a laminectomy.
You did?
51 years ago.
Okay, and it's holding up?
I think as you get older, you know, arthritis or whatever.
Yeah, yep. So that's the next one down, degenerative stuff. Osteoarthritis, degenerative disc disease, facet hypertrophy, stenosis, spondylosis. There's a lot of these terms. Spondylosis is sort of like a catch-all for degenerative changes that happen in the spine. So if you say I have arthritis of the spine, many times if you look at an x-ray finding or an MRI finding, if you have the readout from the radiologist, it'll say spondylosis, multi-level spondylosis. You might see something that says facet hypertrophy. The facet is the actual joint in the spine that communicates with the level right below it. And hypertrophy, hyper is bigger, trophy, it's a growth. You have bony growth, so you have bone spurs, right? In knees and hips and shoulders, and you get them in the spine as well. The complicating thing with the spine is many times as we age, we get multiple things going on. We have arthritic changes, which can be at the level of the joint, so your joints can get a little bit bigger from it's just pressure. So bone-on-bone contact creates a stimulus, and your body, when it has pressure on bony aspects, it grows more bone. That's a natural response of it. So when it grows more bone, it happens to be anatomically located right next to what's called a foramen, which is a hole that the nerve comes out of. So you can get some narrowing of that hole because arthritic changes are blocking some of the prior pathway. It also happens to be, that foramen happens to be right next to the disc, and the disc is really just a fluid sac that separates the bony elements of the vertebrae from one another. So you can have, this is very common, I'll get somebody, let's say in their 70s, and they come in with back pain, and they had an MRI, maybe they had x-rays, maybe they didn't have anything, but they've got pain that's local to the back and maybe referring down a leg. But the people that do get radiographs or some kind of diagnostic testing, we can check the results, and oftentimes it'll say, multi-level bulging or herniated discs, typically in the lower half of the lumbar spine, L3, L4, L5, or S1, so it just identifies the level. So now you have, it's like a water balloon. If you squished a water balloon with pressure, it would squirt out on the sides, right? So a bulging disc is like that. A herniated disc would be, we just ruptured the seal of that balloon and we had seepage of the disc content into the areas that are around it. So you can have those injuries superimposed with arthritic changes, so hypertrophic changes at the level of facet, and even just general narrowing, so the disc height is shrunk down because as we age, we tend to compress like an accordion. So you have all these factors that can create pain. So when we look at treating options, there's a whole bunch of different options, but we sort of have to try to whittle all that out when we're treating somebody to figure out what's really causing the pain. Because oftentimes you can have some crazy findings on an MRI or X-ray, and it's not really the cause of your pain. It can be something that is just muscular in nature, and you can get completely better from your back pain, even though an MRI would defy you to tell me, I'm going to get you better. Other things, scoliosis, an abnormal lateral curvature of the spine. So we see somebody come in, and they might have a cocked up shoulder, or their hip might be up like this, because they have compensations. Their spine has taken on an abnormal side-to-side curvature, either shaped like a C, or oftentimes it's shaped like an S, where the bottom half of the curve is down here and the top half is up here. So on one side of the curve, on the convex side, you have things that are too long. On the concave side, things that are too short. It can create some asymmetry of load when you think of that person and how their body weight and gravity, kind of work together on, supporting the spine. You have dual parts with an S-shaped curve of asymmetry. So shortness and tightness on one side, length on the other. So that short side, oftentimes we'll see arthritic changes on the short side only and not on the opposite side. So you get abnormal wear and tear patterns one side versus the other. You get the one slide before said compensations. So you get someone that's been hiking a hip for many years and they get a leg length discrepancy maybe. Or they have a shoulder that's higher, which makes the shoulder blade muscles weak, and now they've got shoulder pain and neck pain because of that, even though it's coming from their spine. Again, it's complex. Spondylolisthesis, you've heard of people say I have a slip disc, right? That's probably the true definition of a slip disc. A spondylolisthesis if I had an anatomy, a dummy here, we'd see vertebrae stacked up in line, and they should be pretty much right in line with one another. But the spondylolisthesis can happen either forward or backward. But with respect to front to back, so if these two things were the vertebrae and the space in between my hands is the disc, one of the vertebrae is slipped forward. It's moved. But the one above it isn't. So this one is forward of the one in front of it or above it and the one below it. So it literally just does start to slide. It's kind of treated as an unstable condition. All the ligaments and stuff are still there, but again, it shifts pressure around on the disc, on the joint tissue. So you can imagine if I bend one way and this is sitting out too far, pressure one way might feel better, pressure the other way might feel worse. So we go about treating it differently depending on what that is. And then posture-related dysfunction. So plenty of times people will come into the office, they'll have pain, we do a low back assessment, and we run the gamut, range of motion, joint mobility, leg strength, sensory changes, everything looks normal, reflexes look normal, and we evaluate really what their body looks like when it's in a static position of sitting, especially is how I look at it, and I can start seeing that they have poor posture control. And now we talk about what they do for a living, and they sit at a desk all day in front of a computer. Or maybe they did for 30 years during their job and now they've just, have pain after they retire because they're getting more active trying to do things, they're putting stress to their body. But we start monkeying with their posture and fixing it through corrective actions, and we see that really just that alone starts making their back pain get better. And a lot of it's moving parts of your body that you haven't moved a certain way in a long period of time. So treatment for low back pain, it can be as much as nothing. And I say that not to joke around, but sometimes if you just wait it out, your body will get rid of the inflammation and it'll go away. And that's happened to probably plenty of people in the room, yes? You guys have had back pain that's been recurrent. It'll go away within a week or two, right? And you live your life and you're good for a few months. And then you do something else and you wake up one day and you have back pain, and it sort of ebbs and flows like that. Does that sound right for some of you? That's okay. It ebbs and flows. Like I said, you could have a recurring inflammatory cycle because of a bulging disc or a herniated disc. And it, depending on the stress you put on it for a short period of time, irritates it, and then you take that stress away and it goes away. It goes dormant. Does it heal all the way? It's arguable. Probably depends on who you talk to. I happen to think disc injuries do go dormant, and heal, maybe scar over, and then it doesn't become an injury that has inflammation with it and the pain goes away. But one of the things is if it's recurrent over and over again, it tends to recur more frequently over time. So it may be 2 years between back pain episodes, and then the second one comes on, and the next one is only 9 months after that second one, and then it's only 3 months, and then it becomes, geez, I can't really function without pain when I do this all the time. Aside from nothing, rest, medication, so OTC, over-the-counter or prescription medication, so you go see your doctor. How many people have been given prednisone for back pain? A few hands are going up. Did it help your pain go away?
No.
No for you? No? Yes? Yes? It's hit and miss, but it's an often prescribed medication for inflammatory things. So maybe it didn't help your back pain, but it might have helped your knee pain. But it often does help a lot of people because it takes the wind out of the sails of some of the inflammatory processes in the body. It can help, and if that's all you want to do is get rid of your pain immediately, it can help some of those people. Again, I'm sort of building a pattern for, we probably need to get more active to treat back pain, but nothing and rest, medication, they do help a lot of people. You could try to have more physical activity. So some people come in and see me and say, yeah, I have this back pain that keeps coming back. I have had it now for 2 months. It doesn't seem to be going away. I know I need to lose some weight. So that's probably going to help, right? Yeah, that should help. Certainly take the weight off. It's going to be less stressful. But a lot of doctors, if you go to a primary care physician, they'll just tell you to start walking more. And even there were some surgeons when I was a young therapist in the area, that was like they didn't send people to physical therapy until they really needed it somewhere afterwards. But they had back surgery and the only prescription for them was to walk a lot. An undefined amount, but just walk every day. And that was sort of like the one of the primary rehabs for people coming out of back surgery. So folks that don't have any major intervention like surgery, pain management, and who has been to a pain management doctor in the room? Any hands? quite a few. Some others that might not be telling me. But there's not a lot of people, I shouldn't say it that way. There are a lot of people out there that don't want to put work in to get better. They want to take something because it's quick and easy and, gets rid of some of that immediate pain. And I get that. But, in the truest sense of getting through an injury, we need things to heal. We have to correct things that are maybe the causing factors of that. And that's where it becomes sometimes difficult. As a physical therapist, we help a lot of people with back pain. And like in your situation, your pain can go away completely and hasn't come back, which is what we hope for. But if there's certain amount of changes in the body, skeletally or soft tissue-wise, where there's damage, tissue once damaged is always damaged tissue. So it heals with scar tissue. It can heal, from a stability standpoint, but it's never as good as your native anatomy. So we're working with damaged goods many times when we get you into our office. But damaged goods can still be pain-free, and they can still function at a really high level. Look at pro athletics. How many people get catastrophic injuries, right? Complete ruptures of tendons, and they blow their knee out, they blow their shoulders out. They come back and they play a pro sport. So it can be done with replacement parts like joint replacements. It can be done through reconstructive surgeries where you take a cadaver ligament and put it into the human body, and it all of a sudden takes on a new life and can serve as the new ligament. So you don't want to think that you have a death sentence on function because you have some pain or some injury in your body. There's typically ways that we can get people doing much better. But pain management, to finish that thought, in my experience, it's injections. Yes, ma'am?
I just have a question. Would laser treatment be a possibility in there, or? Yeah,
sure. I probably didn't put everything on the slides that is out there to be done. And that might fall more into the realm of somewhere down here with physical therapy or chiropractors. Some pain management doctors might have those. But pain management doctors typically work hand in hand with physical therapists a lot of times, because that might be how someone gets started in the physical therapy realm of treatment. That might be in concurrent state with injections and pain management medications. There's some local pain management doctors that are newer to the area that are doing some neat things with pain stimulators, especially for shoulder arthritis. But in low back areas, they have some implanted pain stimulators where they're only in for a finite amount of time. I've worked with people that have kind of permanent implants, and then they have to deal with, does the battery have to come out or get recharged and put a new one in? This fellow I'm talking about, he does more like a 60-day trial where it's in for 60 days, they ramp it up, and it has some lasting effect afterwards. It can be repeated somewhere in the future. Other referral avenues would be a pain management doctor, maybe they are the first people to order the X-ray or MRI on you, and it looks like you've got a significant injury there. So they may send you to a spine surgeon, they may send you to us as physical therapists to work with you, they may do both of those. So it's sort of pain management folks are more mediators of, what can we do to help you mitigate your symptoms? And to your point, it is management. So it's an understanding that you're probably in a situation where you are likely to have ongoing pain or recurring pain, but how can they help you manage your day-to-day life with that? And then when you come to me, I feel more obligated to fix you. But I am always optimistic, but obviously we're trying to be realistic. But in terms of physical therapy, chiropractic care, massage therapy, whatever else, there's all kinds of things you can do in here. But three of the more common things in this area are PT, chiropractors, massage therapists. At the hospital system and even in private practice, I was there for a long time. Massage therapy oftentimes these days is not necessarily incorporated right into physical therapy plans. It used to be when I was a young therapist, there were several offices that had massage therapists that worked there every day, and part of the PT plan of care was you did exercise, maybe you got some modalities like electrical stim or heat, and then you went and saw the massage therapist as part of but then people were there for like an hour and a half or 2 hours, and I don't think it was really feasible to commit that much time to physical therapy 3 times a week doing it that way. And payment for those things also changed over time through insurance companies. But I can't speak to chiropractic care. How many people for your back pain have seen a chiropractor? There's a good number of you. How many see a chiropractor still in an ongoing basis? And that's typical, I think, is the lens that we look at care in PT and chiropractic is a little different. We're just trained differently, but we're both trying to do the job of helping you get better and help your pain. So in my opinion, we should probably work more proactively with chiropractic care as physical therapists, but for some reason it seems like they're more adversarial than they are on both sides. And I don't know why, but it just seems that way. It's probably egos that get in the way. Like, we think we're trained to be the best expert, and someone else thinks they're trained to be the best expert. That's my own, I get off my thing. But opinion-wise, I've always thought we should work more in line with, with what chiropractors do, because I think it can be a good product.
A quick question.
Yes, ma'am.
UH really promotes, their wellness institute. So along with physical therapy, because everything is nerve related, what about acupuncture?
What about it? No. We have acupuncture as kind of a holistic approach to things. That is.
I'm wondering if those two are in tandem. Like, if you're working on the physical part, if you're out of alignment or you don't have correct posture.
It's an interesting question.
Impacting the nerves, which there's the yin and the yang, and
yes,
sitting correctly or torqued or whatever.
So I've got this term dry needling. I'll just explain in a minute. That's using acupuncture needles, but it's not acupuncture.
Okay.
So again, in the industries of doing what we do for healthcare, acupuncturists, and this is just sort of what was sort of explained to us when we were going through dry needling certification, there's sort of a rift between people that do acupuncture and people that dry needle, and we use the same tools for different reasons. We see it through a different lens. Acupuncture is kind of Chinese trained. It goes back hundreds of years, and it looks at meridians and energy flows and how the nerves, so you might get a needle in your hand because you have a somatic issue in your stomach. I'm going to put a needle in your thumb because I think you've got a muscle thing going on in your thumb that's causing thumb pain. So I don't really look at it from, I might put one in your back because I think you have referred pain into your leg, and I think that's the source. Maybe I go up here where I think the nerve source is, but it's almost all from a musculoskeletal standpoint approach as opposed to thinking of it from a Chinese medicine angle. It's a good question though, because we do have people that go see acupuncturists, like certified acupuncturists.
Under UH, I thought.
Yeah, but at the same time as they're getting physical therapy.
Gotcha.
And it's okay. I think whatever gets you better, let's get you better. If that takes 3 or 4 people to do the job, then by all means, let's just get you better. So a typical day in physical therapy for me is someone gets referred for low back pain, and we go, the first visit is usually the evaluation. So speaking from my own personal approach, we're going to sit down and talk for at least 10 or 15 minutes. As I'm taking data, you're telling me your story. So you're going to tell me when it first started, what's been your treatment for it so far, have you had diagnostic testing, has anything that reveals structural damage? If so, what was the treatment for it? How did that treatment help you? Did it not help you? What are the things that make your pain feel better? Have you found anything on your own? If not, what are the things that make you feel worse? And then, once we sort of collect that data, I'm going to put you through, depending on how painful you are, I'll try to put you through a physical exam. So I'll look at how much your spine moves. And I'll look at the areas above and below. So if it's your low back, I'm probably going to go all the way up to your neck. I'm certainly going to look at your legs and your hips. We may or may not test strength. Again, it's sort of, sometimes I'll have someone in front of me, and whatever they tell me in the interview, it just spells out what I want to do to start treating you. So we'll just jump right into treatment for it. I won't even worry about, can this person bend over and touch their toes? How's their range of motion backwards? Can they twist fully? Because some of that stuff doesn't really matter. If I think I can get you better through treatment techniques, we're just going to jump on that bandwagon. At some point I have to take data down though, because unfortunately, insurances tend to drive the bus, and they want to see reproducible change. So if I don't have any baseline measurements on your motion or strength or functional things, then if we have an insurance issue down the road, I don't have anything to compare it to. So somewhere along the line, we're going to get all that data down. So, that evaluation can be, all-encompassing. But typically the first day, we're going to try to get you something to do at home to take care of yourself, so you don't need to rely on us to do it every time. That could be positional things, meaning I want you to, lay on your stomach for 5 minutes every 3 hours or something like that. You have your eyes are like, what? That could be, I want you to, twist to the right 10 times every 2 hours. But that's generally in our evaluation, we're going to try to find a comparable sign. So something that has a definitive action to it that makes your pain happen, and then we're going to try to find what makes it go away. And sometimes we just have to take you through different things, like being on your tummy, or maybe doing like knee to chest, or sitting with your torso bent down, like your hands kind of touching the floor. Or again, through the years of working, there are different models of treatments that we can do that tend to work for people. So the therapeutic exercise, that could be as simple as positional things, and we find that, when we have you do this many times a day, your pain level goes away when you do it. And then we do it 2 or 3 days or 4 days in a row, and after a week, you no longer have any pain down in your leg, and it's all in your back. So we've centralized your pain to where the origin is coming from, and you have no more sciatica. So we put you in the driver's seat for taking control of your pain, and we didn't use medication, and we didn't use anything into your body that wasn't already in it. The other parts of therapeutic exercise are, do I need to get you stronger in your torso? Probably so. Anyone that has low back pain, or especially repeated low back pain, I could probably, not going too far of a limb, and say 100% of those people need to get stronger in their abdominal muscles, and their pelvic girdle, and their rear end muscles, and their low back muscles, because that really controls the stresses of what surrounds the lumbar spine. And most of the people that have pain go into some type of guarded disposition where those muscles are either inhibited by your brain. From a defensive standpoint, they sort of shut those muscles off so they don't function as well as they should. Or on the converse side of that, maybe they're in a spasm. Maybe they're just super tight all the time and they can't move the way they should because they're kind of locked up. And we have to teach those muscles how to relax and restore movement again. So that's everything from exercises lying down on your back, on your side, on your stomach, seated exercises, standing exercises. It depends on the person. They may have, arthritic knees, and I can't get them on their feet and do work, with any kind of knee bend because their knees flare up. So we have to just pick and choose what we do based on the other things going on in someone's body. Manual therapy techniques, soft tissue manipulation, that's a fancy word to describe some type of massage typically. Joint mobilization, that's more of a thrusting kind of movement with our fingers into a joint area that we feel is tight. So we will have you either lying down on your stomach or back, sometimes on your side, but we will find more localized force, or maybe I'll use my whole hand if I want to segment, and we will literally apply repeated force at a certain load that tries to make a joint move that hasn't moved, or doesn't move very well. Myofascial release is more of a connective tissue release. Again, typically it's using our hands, and we apply force to tissue in more of an elongated way as opposed to massage, which kind of gets down into tissue. So instead of being down in tissue, it's more a horizontal longitudinal application, and it tries to release tight areas of connective tissue from holding down nerves and blood flow and all the other things. Manual traction, so if we think you have a disc injury, that the disc is putting pressure on the nerve, we might pull on your hip or your leg, or if it's the neck, it might pull on your head and neck area, but trying to literally decompress the area, so we add a little space between the compressed segments. Stretching could be considered a manual therapy depending on the type of stretching we do. Dry needling, I'll leave that for the last to describe. So to your question about acupuncture, dry needling is just a physical therapist term for using acupuncture needles. I've been doing it for about 5 years now. And out of the 22 years of being a physical therapist, if I could pick one thing to do for somebody that has the biggest effect on taking pain away and the longest lasting ability to do so, it would be dry needling. Yet I've only been doing it for 5 out of the 22 years. So it's come on strong the last 6, 7, 8 years in physical therapy. The research for it began back in like the 1940s, and it was sort of born out of doctors doing trigger point injections. Okay, so trigger point injections have lidocaine or some kind of medicated product that's supposed to kill the spasm or trigger point or break that down. And in doing research for that, any kind of research from a medical standpoint has to have control groups. So most of the control groups had either a saline dose, so kind of a null dose, no medication, or it was a dry needle, so a syringe with nothing loaded into it, it was just a needle stick. And out of the 3 groups, the medicated group and the dry needle both showed very favorable uses for decreasing pain. So the researchers are thinking, why inject somebody with something if I don't need to, if just the needle stick is doing that? Needles are relatively large compared to acupuncture needles, syringe needles. So over time, it kind of morphed into using these little monofilament metal needles, acupuncture needles, that do less tissue trauma, but can still get down into the area that we want to get into. So particularly for low back pain, those muscles oftentimes are just locked up, right? People talk about having a back spasm. I feel like my back seized on me. I mean, you can describe a lot of ways, but along the middle of your spine on either side are paraspinal muscles that start from your neck and come all the way down to your butt. And oftentimes those muscles are really tight because they're just trying to guard you against the pain that you're in. So we could have you lying down for a treatment doing dry needling, and we're going to probe for tender areas. And you might say, yeah, it's tender all the way up to my bra line, even though it's low back pain. So we'll start where we have pain, and we'll run it all the way down through a painful zone. And we'll put a needle, we'll insert the needle into a muscle, so it's a protected area. We don't go out wide where they have lung fields and stuff below that. So we stay in bony areas where it's protected by bone. But we might insert a needle 30 millimeters, 50 millimeters, if it's down here by your rear end, 70 millimeters into your body, into an area of muscle that we think has a trigger point. And the thinking of the research on it is that it quiets down the trigger point by breaking the brain and muscle signaling system. So when you have pain, your body senses that, it sends a signal back to your brain senses it, and it sends a response signal back down. So that response signal reaches down to the muscle area, it releases a neurotransmitter that your muscle senses, and when that senses it, it opens up another area, it lets calcium flood into the muscle, which creates a contraction. So it's this ongoing revolving door of pain goes up, response comes down. Nothing's stopping the pain. Pain goes back up, the response comes down. So you have this revolving door of pain spasm cycle going on. And the thinking is the needle, when you get it, especially in the right spot near the trigger point, is it sort of blocks that response back from the brain to the muscle. So it shuts off acetylcholine from being released into the muscle doesn't sense that. The calcium kind of goes back into its holding tank, and the muscle therefore can finally take a breather.
Oh, so it's breaking up the trigger.
It stops the trigger point because it can't physically contract anymore.
Gotcha.
So I've had RFA 4 times, so the difference would be the radiofrequency versus just the needling position?
Yeah, the radiofrequency ablation, it's more like burning off your nerve endings that are going to regenerate at some point. So, if your nerves aren't in the area to promote a motor response or have a sensory response because, you've sort of taken them out of the equation, that can help reduce your pain. But I think, when those nerves regenerate, if there's still some signal there to be sensed, it's going to resense that.
So this could be an alternative if RFA works, then needling, could it be an approach?
Yeah, I try needling on almost anybody that lets me have, if they have pain, no matter where it is in the body. Honestly, I do it probably over 50% of the people I see, I do it on.
It's interesting because of everything you said so far is the only thing I've never done.
Yeah.
And I've been doing this for 25 years.
Yeah.
So it's kind of interesting to hear something I've never heard.
Yeah, the first aha moment for me was about a month after I was taught, to do needling. I had a woman who had a prior back surgery, and she was functioning. She was our office was over in Heisley, and she walked like 4 miles a day. But she would tell me every single day that she walked, by the time she finished her walk, she had a ton of back pain, and she just she lived with it. She'd wake up the next morning, didn't feel too bad, walk for exercise, and had pain. So I'm like, hey, why don't we try some needles around your scar area? So she had a lumbar incision, kind of midline. We did needles on either side of it. And next time I saw her was only a few days later. She was like, I got to tell you, I didn't know what it was. Something was weird. The day after you needled me, she goes, I couldn't figure it out. But when I got done with my walk, I didn't have pain for the first time in like 5 years. We did needling one time. I mean, that's just one time for that one person. But I've had plenty of other episodes where, you use those needles and, you've had massage and you've had things where they try to work soft tissue out. But, in my opinion, I'm at this point in my career, I feel like I'm fairly well skilled with my fingers and be able to assess and treat muscular conditions. But my over-the-skin skills pale in comparison to something that can get down into the actual cells that need the help. So many times we'll find a hot spot, we find the trigger point. So I kind of call them exploratory needles. Like we have a general idea of like when we palpate and we feel tender areas, so we put the needles into the tender zone, but you might find one that like makes you have a little jump sign. And when we get that, then oftentimes I'll say, okay, there's my epicenter. I'm going to put one above, below, inside, outside. I'm going to try to find sort of the epicenter of like where that thing is coming from. So if I do find that hot spot, I tend to cluster them right around that. And then, sometimes depending on where I'm needling, it just might keep following a line. So that one was, that was pretty good too. And the one next to it, so it just keeps following along a specific muscle tract, and we sort of unlock things. It's adjunctive, meaning, it's an adjunct to other stuff we do. It doesn't take the place of getting stronger and all those other things. But if pain is preventing you from getting stronger because you just inhibit it all the time, and that breaks the pain barrier down, then it's a pretty nice use of some of the tools that we have in our bag. And I do have some people that find that needling is one of the only things that gives them the relief they're looking for. So in that case, I'll have people come back sometimes only once every 2 or 3 months to get needled in their area just that one time, and then they're good for a couple months. So I might see them, 4, 5, 6 times a year just for needles. And that's fine. We can do whatever you want to get better. If that's what helps sustain your activity, then good.
So you needle and you take the needles out before they leave. Right?
Yes, I was going to make a joke, but yeah.
I just want to make sure.
Yeah, now there are different techniques. Some people, they plunge them in, they take them out, and they're done with it. They're single use. They're in a tube that is sterile. So the way I was taught, we put them in and then we leave them in for about 10 or 15 minutes statically. The other effects other than trying to find the trigger point is, so it's also become not just a trigger point release, it's become, we treat sprained ligaments with it, strained muscles with it. So tissue areas that just got hurt 2 days ago, they're torn, right? So muscles like this, it has a tear in it. So if we think you tore a muscle in your low back, the muscle's separated and it needs to seek a healing where it gets back together and tethers. But to help that happen, if we put needles down into here in a certain collaboration of needles, there's a bunch of blood flow that happens with the needles. So you put that in, it creates a low-grade inflammatory response. So it's so low-grade, it's not damaging in any way. But you bring extra blood flow into those areas trying to heal. And inside the blood flow is oxygen. Inside the red blood cells are stem cells. So now you've just created a small column of tissue damage, think of it that way, that has to re-heal quickly because it's so small. But now you've got all this blood flow, stem cells, oxygen in there, and these little columns of growth to happen, and it helps rebuild new cells around healing tissue. So again, if I take a knee sprain, for example, I might cluster, if I think someone sprained their medial collateral ligament on the inside, I might take a small cluster of 5 or 6 needles on that ligament. They only go in 1/4 of an inch because it's not very deep at that area. And we might do it for 2 weeks while the ligament's trying to initially heal.
So is a trigger point and a adhesion two different things or the same thing?
They're different.
Okay.
But to your point of a trigger point is just a hyper-excited, tense area in a muscle. That one, myofascial release, we tend to do a lot of myofascial release and dry needling hand in hand. So if you've had a trigger point for a long time, it's a spasm, right? It's a hyper-excited area that doesn't want to release. So it's not just the muscle that gets tight. It has all this other soft tissue around it and running through it. Right, so we have planes of muscles that are separated by layers of fascia. So that's within the muscle. So like you get a steak and you see those white kind of, that's a fascial plane inside a piece of meat. Right, you see it in all kinds of, we're no different. That's just muscle. Right, so our muscles have fascial layers within them. And then you have like the superficial layers where you think, okay, there's the dermis, the skin, then you have fatty tissue, and then you have kind of, if you took a dissection of it, you'd see this film. It looks like a piece of saran wrap almost in color, but that's sort of overlapping all that. And then there's different layers of that within the different. So again, if you're dissecting it in surgery, they just go in and they can just rip that apart with their finger. They can take it apart with a scalpel, but it's easy to tear. And it's sort of put together through little microtubules and all kinds of like connective tissue elements. But with respect to that trigger point, as it's tight, everything around it gets pulled into it. So it's like, this tightness, is here as a trigger point, but look at all the tension points in my shirt around it. It's pulling tension into it. So I might be able to needle the trigger point and kind of break that up a little bit, but we still have some residual tightness. So then I might take my hands and, try to separate that tissue, flatten it back out, not massaging it necessarily, but like really trying to take that connective tissue layer, the fascial layers, and and pull them that way, and then maybe I'll mobilize them once I get them spread to create better mobility back through there. So again, things are sort of adjunctive to one another. And then once we have that loosened up, then maybe the next visit we can exercise more because you're feeling better. So it's a tricky set of things. Like I said, your initial diagnosis that gets you in the door could be anything. Could just be low back pain, evaluate and treat. Okay, well, let's talk about your back pain. How'd it happen? Or you could have had all these other workups done. You could have seen 3 different pain management doctors, a spinal surgeon consult, your primary care physician, didn't care for what they said, and they're sick of seeing you, and they just send you to physical therapy and say, go try this. So that happens to a lot of people. But I feel like when you come to see us, we want you to leave optimistic that we're going to get you better. It may take some work. The body's like a puzzle. So if we can break the puzzle down and find the pieces in the right parts and put it back together, oftentimes we feel better, if not all the way better in your situation, but we at least feel better than we did. And if we can improve your function that way, that's obviously ideal. Posture, she moved. I put this in here because if I can give you one take home from today and dealing with your own pains, I'm sort of, no one take offense to this, but I call myself like a posture Nazi. So I feel like posture has a lot to do with the development of pain and how we deal with pain, because we have things called pain postures, right? How many times do you see someone splinting an area in their leg like this because and now their face is grimacing, or they're shortening up their torso here because their leg hurts, or they start walking more like this because their back is hurting them, right? This has a posture to it, right? Or if you don't have any pain, you walk free and easy, right? No problem. But we all tend to do something when we have pain. We all tense up in some way. It's inevitable. And so when I look at people with chronic back pain especially, their pelvis usually doesn't move the way it's supposed to. Okay? So your pelvis is supposed to rotate forward and back, right? So in standing, I can tip my pelvis forward and get a sway back. I can tip it the other way and kind of get kind of like a rounded back or hunchback. When we walk, as your hip goes forward, your pelvis rotates one way with the front leg, the opposite way with the back leg. And as we advance the next step forward, it switches. So it's counter rotation, right? So one side rotates forward, the other side rotates backwards. People with a lot of pain tend to have less movement of that. So they have shorter step lengths. They have less powerful step lengths. They walk slower, right? So when you look at realms of normalcy of movement, things aren't normal for a lot of those folks. But the way I teach posture is I have people think of their body as a building, right? What does a building or a house need to be sound? Foundation. So that's your pelvis. So I don't give people the answers when I first see them, but if I start talking posture to people, and I come from the side and they know immediately I'm looking at their posture, and they just say, I know, I don't have very good posture. I'm like, okay, you might be right. How would you, if you give me your best textbook posture, what would you do? What would you guys do? If I'm looking out of the crowd here and I say, give me your best posture right now, I'm looking out at all of you. What would you guys do? Sit up straight, shoulders back.
Keep your stomach pulled in.
Put your feet down.
Flat on the floor.
All right. So that's all correct. But I don't know that I heard anybody voice, I rotated my pelvis under my spine. Okay? So if you don't mind, sit slouchy for me. Okay? That's easy. You guys are pros at that. All right. So if I had my hands on the front of your body to give you it's just stability here, and I said, okay, take your low back and put a forward curve in your low back. Can you feel how it drove your body up tall? Let it slouch. Your pelvis rotated backwards. Rotate your pelvis forward to be tall, right? Or back to slouch. How many people does that hurt to sit up tall? Does it bother your back, anybody?
A little bit.
A little bit?
I get that if I sit in a chair too long. When I first stand up, the tendency
To be here. Takes you a second to kind of get upright?
and walk several strides and then I can straighten up.
Yeah. You probably have some stiffness to your pelvis that it's used to one position, then you change positions quickly on it, it doesn't like it.
Or if I stand too long.
Yeah. So to whatever extent you can see me. So I'll sit slouchy on purpose. Okay? So I'm going to rotate my low back forward. I'm going to put a curve in my low back. So watch my posture change as I rotate my pelvis. I didn't do anything up here, but it moved, didn't it? Right? Slouchy. Not as slouchy. So movement pattern number 1 is to give lumbar rotation. Put your hips under your spine. So this is putting the foundation under the building. Okay, so if I was next to you, I'd probably give you just support on the front of your body, and I'd put my fingers in your low back, and I would say, sit up tall. I'd push a curve in your low back.
I take a little packed aerobics and we have a ball. We put it behind us and it's going back and forth like this. Because you know, when you go back on the ball, your stomach goes in and then you release it. So that's kind of a good exercise.
Yeah, it's kind of an assistive tool to help you do that, right? That's the same philosophy, though, as what I'm trying to teach people.
Right.
But if you can control your pelvis better, you'll control the foundational support system for the rest of your spine, right? So when I sit slouchy, I look like the letter C, right? I'm C-shaped from my butt to my shoulders, and my head's out in front of me, right? My shoulders are kind of curved forward. Just my pelvis alone, I correct some of it. Second level up is about bra line for a woman, or mid-back. If I said to lift my chest, see my head and my shoulders come up when I do that? Okay, see that? Okay, you guys trying that out there? All right. So those 2 corrections alone, the pelvis first and then the middle back second, probably account for about 75 or 80% of the movement change you need to make happen. The third one would be, bring the shoulder blades back some. So not a full-blown military correction, just some. And then the last one would be like bringing your chin back like a chin tuck. So they're kind of listed under here under the 4 components of posture correction. It's work to stay there. It feels awkward. It feels unnatural. And it looks a lot better than it feels, to be honest with you. People don't believe it, but I just take my cell phone or take their cell phone. I say, can I take a couple pictures of you? So I'll take them at slouchy. I'll take them with the lumbar rotation, the thoracic extension, the shoulder blades, the neck, and we'll compare the stages of the posture correction. And as awkward as it feels to be upright like that, it looks so much better. And people oftentimes, it doesn't feel great if you hold it for a long period of time because your muscles aren't used to it. Your joints aren't used to it. So it feels like it feels worse than sitting slouchy. But when you think about how the body's angles come in, if your head's sitting out in front of your head and your neck area, those back-sided neck elements are just pulling up against 12 to 15 pounds is what your head weighs. They're just pulling up all the time no matter what, just to kind of keep your head upright. But if you got it more vertically stacked, so if I said, okay, let's go upstairs and let's take as many books as we can and stack them up on your hand without letting them fall down. I'd stack them vertical, wouldn't I? I wouldn't stack them off at an angle because eventually that would what? They'd fall. Well, so does your posture. You're just held together by ligaments and soft tissue. Otherwise your head would be falling down to your chest. But it doesn't because your muscles are pulling up against it. But if this weighted thing is sitting out here in front of you and your shoulders are rounded forward and now your upper back muscles are having to work hard just to hold you up against gravity, that's more work than being here when I'm balanced. It just doesn't feel like it's less work because you're not used to it.
What does a good chair look like? Like she mentioned the ball tool, I guess, to work on your core while you sit. There used to be that knee chair where you're like sitting like.
Yeah.
What does the perfect chair look like for sitting?
I don't know if there's a perfect chair, to be honest with you. I mean, typically it's something that, when you sit deep into the chair, your low back is able to feel a little support from the back of the chair. Some chairs at home, like dining room chairs, have an opening and there's only like the high back to it and has an open space. Things that are too squishy are hard to get good part because it makes you want to sit slouchy. So something that's got a firm base to it, something that can allow you to sit like you are with your knees at 90 degrees, your feet on the floor, your hip angle between your thighs and your torso around 90 degrees. So ergonomically, if I'm setting you up for like a new workstation, I'm probably going to try to find a chair that allows you to have 90-degree bend at the foot and ankle, 90 degrees at the knees, 90 degrees at the torso, 90 degrees with your elbows, about there. But something that you feel like, lends a little bit of support to your posture. But ultimately, your best chair is your muscles. your awareness.
Here's a side note. That's a good question. Now, my mom's 95 years old. We never grew up with a recliner. You go in anybody's house now, they got the recliner.
Sure they do.
And they have their feet like that, so of course that's not helping posture.
Right.
I mean, everybody's got their feet. Well, she elevates her feet,
Yeah.
of course.
And it's okay. I mean, you'll catch me when I'm doing some of my notes during the day, sitting slouchy, but I can command my posture at will. I can hold it for about as long as you want me to, but I try to practice what I preach. So this is more of a habituation for people that need the correction, because let's take you, for example, ma'am. You said you've had many, many years of low back pain. You probably won't tolerate doing this for very long right now.
What, the posture? I don't do it, then I will have problems, so I do it.
So you do. So you're more aware of it.
Extremely aware of it.
Okay. But a lot of people that come in the door that this is a first time discussion with, they can't tolerate correcting it for very long because they get tired. Their muscles start to ache in their back because it's fatigued. And I'm talking like 30 seconds, not like 5 minutes worth of posture. Or we get that upper back part going and they literally don't have enough motion or strength to hold their upper back up because that's a foreign movement to them. But I try to get people habitually corrected by timing it. So today we all have cell phones, or we have microwaves at home, or on your oven timer. If you set a timer to go off minimum every 30 minutes, you're getting 2 times an hour. I usually tell people to do it every 15 or 20 minutes, so they get 3 or 4 times an hour. To sit upright in the corrected suggestion for 1 minute at a time, every time they do it. So, if you're retired and you're at home, do whatever you want, but let that timer go off and just stop what you're doing and correct your posture for 1 minute, then go back to doing what you're doing. If you're at a red light when you're driving your car, do it at the red light. If you're sitting down and watching TV, great. Sit in your recliner with your feet up. On a commercial break, put the thing down and sit upright for 1 minute during the commercial breaks. So you're feeding it into your day to build a habit, and then once you start making it a habit correction for a couple weeks, this doesn't feel so good anymore. It feels lazy. It feels like your muscles aren't working for you. So you're more apt to at least get your pelvis upright and feel like you're supporting your frame.
I tell my Fitbit to tell me every hour I haven't moved. So therefore you move.
You sit without moving for an hour?
No.
I'm just kidding. Just teasing.
It reminds me.
I'm just kidding. Yeah. But timing it for me over the years has been the best way to get people to do it. I was trying to convince a 12-year-old today that his posture wasn't very good, and it was relative to a hip injury he has. So the hip injury has to heal. He hurt his growth plate. But I can only do certain things with them, but his hamstrings are super tight. And one way, if you want to feel some tight hamstrings, sit up as tall as you can. As tall as you can, maybe away from the back of the chair even. Unbend your knees. Are you sitting as tall as you can? All right, now make one leg straight without giving up your posture. Feels tight on the back of your leg probably, right? So that's because your hamstring attaches to your pelvis. It attaches to the ischial tuberosity of your pelvis. So when you tip your pelvis forward, you're actually pulling the hamstring away from its attachment at the knee. You make your knee go straight, you're pulling the hamstring into a full stretch position. So most of the compensation for that is to give up your posture to let your knee straighten all the way. So for him, I made it into exercise. I said, okay, in the tug of war, your posture's got to win and your hamstring's got to lose. So we did but school-age kids have the worst posture I've ever seen in my life.
What do you think about medical cannabis?
I don't think anything about it. No.
Well,
That's just me. Maybe someone else talking to you might know more about it, but it's not in my wheelhouse to comment on that.
it was just in Dr. Roach's column. And then
How odd, Dr. Roach talking about cannabis. Okay, have I covered topics you guys wanted to listen to tonight? Has it been informative? Okay, so that's going to wrap it up. I just have one more slide. Just says thanks for attending. So, okay, good.